There is a large body of prescriptive literature in the area of clinical decision analysis of really looking at how clinicians should make decisions in looking at weighing of statistical probabilities and so on to reach decisions, but not much really in that descriptive work, and I think a great deal of work is needed in that area. We see finally the last aspect of this model, which shows the noticing, interpreting, responding, is this whole category of reflection. Now, some of this work was spawned in the mid-'80s by Donald Schoen, who wrote a classic work on the reflective practitioner, and it spawned a great deal of research around the globe on what is it to be a reflective practitioner. What do we mean by reflection? What is it that triggers a reflection? What do we gain from that? What's to be gained from that? How does it contribute to the way that we think as clinicians? And Schoen made some distinctions that he referred to as reflection in action, that Benner refers to as deliberative rationality. This is being able to modify or adjust one's response as they're engaged in the intervention. So a nurse, for example, watching a patient as he or she is teaching the patient about their care and assessing the extent to which the patient is understanding, following, tracking, and engaged with the nurse in this discussion, and being able to modify on the basis of that. A skillful nurse is able to do that very easily. We see that shows up very clearly when we put a neophyte in a similar situation who basically can spew forth a lot of information to the client without any read or assessment or modification on the extent to which that patient is following their understanding. So shown reflection in action again, and reflection on action that is critical for the continued growth of the professional. That's the looking back over the practice, looking at these clinical events that often have an emotional trigger because something went awry, but may not, and really give the clinician the opportunity to think back over what is it that went well, what didn't go so well from this experience. It's this reflection on action that contributes to our ongoing learning as clinicians. In my work with Patricia Benner, we interviewed clinicians about their practice as nurses. We had about 130 nurses who participated in our study and asked them to give us narrative accounts from their practice where things had gone exceptionally well, where there had been a breakdown. And we collected over 1,000 stories from nurses about their practice of really sentinel events that occurred to them in their practice where they gained something from the experience. There's a troublesome happening among some nurses and likely some doctors where reflection isn't obvious because you ask a nurse to tell them a situation, these nurses, to tell you about a situation from their practice, and their response is, well, you know, nothing really stands out. Everything seems the same. And it's sort of unimaginable that we could engage in the practice like we do and not have many events stand out. And I think it's part of it seems to be this lack of really that kind of solid reflection on practice. And I think it goes without saying how this links to the kind of debriefing processes that we use in simulation. Here's another example of reflection in action. It's a mouse in a mousetrap talking with another mouse, and the mouse is saying to the mouse in the mousetrap, "Oh, I'm so sorry, here I am going on, and I haven't even asked how it is to be caught in a trap." So it's that thinking back over the practice, reflecting on what it is that we do. So on this broad brushstroke of clinical reasoning, that I think describes broadly what all clinicians do in practice and what we've learned from this body of descriptive work, it tells us some things that we really need to aim toward in our teaching efforts to support clinical judgment. Since so much rests on noticing, on getting that initial grasp, on recognizing that you need to pay attention to a set of cues, it's critical, of course, that we deepen the interconnection of important concepts. We know that experts have this very highly interrelated memory that they're able to draw on, that between experiential knowledge that tends to be encapsulated and the kind of knowledge that draws from textbooks and science, it's that knowledge in large measure, that sets up noticing what's important in clinical situations. It's working with our students to develop a pattern recognition, coaching for a sense of salience, and promoting deliberate practice, where students have opportunities to practice with multiple examples in different contexts with different patient populations. Now, I want to point out that it's in our clinical experience that we gain the knowledge necessary to support our reasoning. Yet in both medicine and the recent study of medical education by the Carnegie Foundation, David Irby and his group, and the nursing study point out some of the limitations in clinical education where students spend much of their time observing, often without having the kind of clinical coach that can help students really see and have all of these important differences pointed out, and really taking whatever is available in clinical practice, not moving toward a deliberate plan or design for clinical education where we could help students begin to deepen their understanding of important concepts, or where they get coached for this sense of salience. We've started some work in Oregon, I'll just introduce very briefly, that focuses on the redesign of clinical education to focus much more purposefully. Now, we're at a crisis point in nursing with regard to our clinical sites, availability of clinical education sites, that I think is true across the globe, as I understand it. There simply are not enough places for us to have students learn clinical practice in traditional ways, where students typically go to a hospital setting and do total care for 1 or 2 or 3 patients. The National League for Nursing sponsored a study of clinical education that was reported out last year, looking at some of the issues in clinical education. It turns out that students are spending about half of their time waiting for something to happen in clinical because patients go home so quickly, the patient they were assigned to care for is gone, and often what they're learning is redundant and has little to do with what they'll actually be doing in practice. We need to really do something about this, more than just decide to move to a different site, decide that we're going to place our students somewhere in the community. And what I think we've learned out of simulation work is how important having clarity about educational goals is, by beginning to think about how is it that we could actually design a clinical education program that would help students develop across the curriculum, where we'd actually think about a clinical education curriculum with purposefully designed activities that would help students develop the kind of skills and knowledge they need for effective clinical judgment. So we're in the midst now of a demonstration project implementing a new clinical education model that purports to do that by having interspersed in regular clinical and actually replacing some of our traditional clinical with purposefully designed learning activities that focus either on skill development or focus on developing and deepening one's capacity, an understanding of concepts and their capacity for pattern recognition. We had a preliminary pilot study that was published last year by Lassiter and Nielsen that looked at use of concept-based learning activities in clinical nursing, where students see a variety of patients who represent some important concept like oxygenation, like growth and development, as it relates to selected patient situations. See the effect of those concept-based learning activities on clinical judgment, and we saw some promising results. In fact, the group that had experience with concept-based learning activities, in contrast to those that had traditional clinical, actually showed some improvement in clinical judgment. So we're continuing to do the work to examine the use of that kind of clinical education model along with simulation, which we've integrated in our curriculum throughout. It's interesting to me that around the country, in the US certainly, a question is being raised by regulatory groups of how much of our traditional clinical can we replace with simulation. And we have a study, the NLN and Laerdal together, I think, are sponsoring a study trying to examine that very question. But at base, there's another question, is what actually is going on in traditional clinical? What is it we're replacing? How can we answer that question unless we really know what kind of learning is already going on in clinical. And I think when you get student accounts of kind of wasting half of their time, it's a very important question to ask. So, back to simulation. It's clear that simulation really needs to be an integral part of clinical education, and as part of the model that we're evaluating in Oregon, simulation is one of a host of kind of clinical learning activities that are designed for the students to progress through. The focus of many of the simulation scenarios that we're using is really on clinical reasoning and less on skill development. The skills or procedures that are used in the context of scenarios are those that have been practiced on part task trainers or other environments. In the scenarios that we're developing as part of the clinical education model are really focused on setting up events that trigger engagement in some kind of clinical judgment, clinical reasoning process, so that we know that we need to create scenarios that trigger this. And in some ways, it's like taking problem-based exercises and placing them within a simulation context to have a scenario that's going to trigger or engage the student in the kind of clinical reasoning that we've talked about. So it should have a great influence on that. It should have some influence, certainly, in our planning for pre-briefing. We have our students prepare for the kind of simulation scenarios that they'll be encountering when they come to the center. And we should be very, very clear about the kind of knowledge, the kind of theoretical background that they need to bring to that situation so that they're not hitting it completely cold, so they have some chance of success of really engaging with the problem as it unfolds in the clinical situation. And a debrief that focuses on clinical reasoning, that really gets at the students asking them, so tell me how that went. What did you notice? How did you, what did that tell you? What sense did you make of that? How did you interpret those data? What did you do about it? What might have you done differently? As a kind of broad framework for our debriefing. And finally, a place that this work really needs to have some influence is in our assessment of competence. Part of some of the reasons that the research in clinical reasoning has been hampered is that we have very few measures of, and certainly no adequate measures of clinical reasoning. We know, of course, that how a student performs on any kind of clinical reasoning will be dependent on whether or not they know enough about the subject matter. But do we have some measures that are sensitive to some of these aspects of the reasoning process? And right now, we don't. We don't really have good measures at this point to evaluate competence in clinical judgment. The question then we always have to ask is, are we making an impact? I think the primary research directions really have to be on how is it that we can help students develop a sense of salience. How do we develop a clinical education program that includes simulation, that helps students begin to recognize and learn to have data basically stand out to them in clinical situations? How do we help them recognize patterns, clinical patterns that occur repeatedly in their practice?